So estrogen plays a key role in promoting the proliferation of normal and breast cancer epithelium. So now we have gone from focusing just on the estrogen to also look at estrogen receptors on breast cancer cells and targeting that. And now even to the point of looking at the downstream effects of when the estrogen binds to the estrogen receptor, those signaling pathways.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Rowena Schwartz, Professor of Pharmacy Practice at James L. Winkle College of Pharmacy at the University of Cincinnati in Ohio, about estrogen-targeting therapies. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome back, and thanks so much for joining us again today, Mo.
Thanks, Jamie. It's nice to be back.
So let's start off today talking about estrogen-targeting therapies. Can you give us a brief overview of the history of these therapies? We know there's estrogen receptor antagonists as well as other estrogen-targeting therapies in this sort of category. So let's talk a little bit about how they've evolved over time in the field of oncology.
Sure. If you really look back to where this concept started of targeting estrogen, say in breast cancer, it actually stemmed from the work of a British physician in Scotland in 1874, where he was looking at the relationship the ovaries had on milk formation in the breast. And what he realized is that the breast was held and controlled by the ovaries. And so one of the things that he did is that he removed the ovaries in an individual with breast cancer and saw some regression of the disease. So what we now know is that by removing those ovaries, what they removed was that source of estrogen. So estrogen plays a key role in promoting the proliferation of normal and breast cancer epithelium. So now we have gone from focusing just on the estrogen to also look at estrogen receptors on breast cancer cells and targeting that. And now even to the point of looking at the downstream effects of when that estrogen binds to the estrogen receptor, those signaling pathways. So we really have started to learn more and more about the biology of breast cancer in some individuals and how it's controlled by estrogen and estrogen pathways.
Wonderful. Thanks so much for that history lesson, if you will. I always appreciate being able to kind of connect where we are now and where things started in the past. And so I think that perspective is always important for all oncology nurses to keep in mind as all of these new treatments keep coming through, just understanding how far we've come and how many changes we've made along the way. You touched on it a little bit, but let's talk a little bit more about the specific mechanisms of action for these types of estrogen targeting therapies.
I like to break them up in my mind, at least, into two categories. We have those strategies or drugs that block the production of estrogen, so that by using these drugs, we decrease estrogen in the body. Strategies are things like taking out the ovaries that we've already talked about, using LHRH agonists to decrease the stimulation of the ovaries to make estrogen. And that's done in premenopausal women with breast cancer that are hormone receptor positive breast cancer. These are ways to decrease production. Another drug that developed in 1998, actually the first one came out, these are drugs that actually block the enzyme aromatase. And aromatase is the enzyme that changes androgens that are produced in the adrenal glands to estrogens. And so by blocking this aromatase inhibitor in postmenopausal women, that their ovaries are not producing estrogen. The majority of their estrogen comes from the adrenal gland. So you can block that production. That's one strategy, to block the production. The other strategy is to block the impact of that estrogen that does exist on the estrogen receptor and on those cells that have estrogen receptors. We used to call those anti-estrogens. So that's how I remember growing up. I always thought of tamoxifen as an anti-estrogen. Well, now they're called SERMs, or selective estrogen receptor modulators. And the reason it's called a SERM is because we found that what we once called anti-estrogens actually can be antagonist in some cells, but can actually be an agonist in other cells. And so instead of saying that they're anti-estrogen, it depends on what the target is. So we now call them SERMs. The other group of drugs that's becoming much more interesting lately are the SERDs, the selective estrogen receptor downregulators or degraders. These are drugs that actually interfere with the receptors and destroy the receptors. Good example is fulvestrant. That's been out for a long time. The newer drug that came out in 2023 is elacestrant. Pretty interesting. Now, I'm going to go one step further. We talked about the estrogen, decreasing that. We talked about blocking the receptor. We now have strategies that block or impact the downstream signaling pathways that estrogens initiate. So now we have drugs that are not classic anti-estrogens that we use in the treatment of breast cancer because of their impact on signaling pathways controlled by estrogen.
Thank you for explaining that. I think that might be the first time in my practice that I was able to categorize those drugs in very distinct ways. So I really like how you created those buckets of like, is it blocking the production? Is it impacting the conversion? Or is it maybe impacting actually the receptors or the downstream regulation, as you mentioned? So I think that's really helpful for me to kind of consider those three options and kind of where these drugs might fit in one of those. So wonderful. Thank you so much.
You're welcome.
So let's talk a little bit now about some of the primary subclasses of these estrogen targeting therapies. And maybe let's highlight a few of the examples of some of the newer agents.
So if we're talking about those that decrease the production, the aromatase inhibitors, those are the ones that block the aromatase and the production of estrogen used in women who do not have functioning ovaries. These are drugs such as anastrozole or letrozole. These are non-steroidal aromatase inhibitors. We also have a drug that probably people don't hear as much about. It's an aromatase inactivator. It's a steroid. That's exemestane. And that's also used in women that don't have ovarian function. Now, blocking the receptors of the estrogens, as I mentioned, we have those SERMs. Tamoxifen is the key one that people probably will see in practice, even though trimethoprim, I think, is still marketed. And then we have those selective estrogen receptor degraders, which is fulvestrant and elacestrant. One of the kind of interesting things about these SERDs is that these novel compounds also reduce the estrogen receptor alpha protein level. That becomes really important when we talk about elacestrant, because when there are mutations in the estrogen receptor protein, this is where this drug is actually indicated.
These are technically a targeted therapy, right? Maybe one of the earliest targeted therapies targeting a certain, hormone or receptor. And so as we move into, and as you just kind of mentioned at the end there, that some of these drugs are indicated for other genomic variations that we potentially need to test for to make sure that they are the right drug or the most effective drug for patients. I think that adds a new layer of complexity to these drugs when historically maybe we've only been checking for ER or PR status, making sure that, this is the right drug for that patient. So it sounds like maybe there's more to be testing for on the horizon for some of these newer targeted agents.
You're exactly right. These are targeted agents without a doubt.
So now let's move into the toxicities. What are some of the most common toxicities, adverse events that we see associated with these types of estrogen targeting therapies, both maybe as an individual agent, if it's something unique, or just generally as a subclass?
So when I think of decreasing estrogen, I think of all the impact that you have with menopause. So things like hot flashes. What I always think about is hot flashes in somebody who's 60 is something that you kind of expect. Hot flashes in somebody who's 40, maybe not as much so. And I always think about the fact, and I can say this as I am in the former group, when you get to a certain age, people in your network talk about how you manage those kind of symptoms. When you're 40, maybe not so many people are talking about it. So one of the things I think is really important is those kind of menopausal symptoms. The other one that I think gets overlooked way too often, unless you're somebody who focuses on breast cancer, and that is on vaginal dryness. And I think that's really important, especially when you're talking about sexual health. So I think talking about those menopausal type symptoms are really important and addressing them. Bone loss is the other thing that I think is essential to talk about. I think that's something that as a team, we can really help individuals that are on these agents manage. Now, if we look at specific agents, then you can look at things like the SERMs, tamoxifen. Certainly, every time I talk about tamoxifen side effects, I just think about when I was early in my career and I used to talk at some support groups and I would talk about tamoxifen having no side effects because we really thought it had no side effects at that time. But we have learned since then that there are side effects because of its effect on other tissues. So one of the things that we have learned is that increased risk of endometrial cancer. And that is something really important for women to be aware of. Also increased risk of VTE, another thing that's important. The kind of odd thing that I want to bring up is that tamoxifen was actually developed to look very similar to a drug used for ovulation. So it can actually induce ovulation. So in women that's still menstruating, if they're on tamoxifen, they have to use adequate birth control. And I think that's really important. Now, for the aromatase inhibitors, again, when they first came out, I remember thinking these were going to be like nice, easy agents. Well, they have their risks. They have the issues of hot flashes, vaginal dryness, bone loss, definitely, and myalgias and arthralgias. And I'm going to mention it here so I don't forget to say it. If you're on one aromatase inhibitor and you're having arthralgias, it's worthwhile trying to switch to another one because you may not have the same effects with the other one. You can sometimes change within class to get rid of that toxicity. Just something to mention.
Yeah, and I think you mentioned it yourself about, when they were originally introduced, maybe sort of relative to the other drugs on the market and the other side effects and symptoms that we were trying to help patients work through, that these did seem maybe pretty benign, like nothing too bad. But I think as we've been more successful, patients are living longer and on these drugs for a long amount of time, those other side effects and symptoms are popping up. And I think, as you said, we have to recognize that these are still impactful to quality of life. And so from the nurse's perspective, from a pharmacist's perspective, I think our biggest role can be in being sure to proactively educate our patients about what to expect and that there are things that we can do to help. As you said, there's lots of overlap in terms of sort of the natural progression into menopause for women versus this is a very abrupt entry into those same symptoms. And so giving patients the awareness of what is likely to happen, when it is likely to happen, and then also just communicating what can be done to help.
I so agree.
Along those lines, what can we do to help? I think, again, sometimes just the notion when you think of just menopause of like, just suffer through it and eventually it'll be over, right? But that's not probably the best approach. I think there are things both for menopause and for the symptoms that very much mimic menopause for the patients that are on these class of drugs. What are some of the pharmacologic strategies or other strategies that we can use for patients to help them manage these toxicities?
Sure. I think starting with the vasomotor symptoms that many women will have when they start these agents, such as night sweats and hot flashes. There's a number of different pharmacologic as well as non-pharmacologic strategies. And I'm going to give credit to ONS for this because there's been a lot of research and it's been published in ONS journals about strategies such as exercise and yoga and different types of non-pharmacologic strategies that really can help women through some of these vasomotor symptoms. In terms of those classical management for vasomotor symptoms, it's important to realize, of course, that we should not use estrogen therapy as hormone replacement in women on these agents, even though sometimes topical estrogens may be used for things such as vaginal dryness. Other types of agents that have been used include things that we use in menopausal women, things such as gabapentin can be beneficial, or sometimes some of the antidepressants such as SSRIs. So we have to be really careful with those because of the potential drug-drug interactions. Beyond the vasomotor, the other thing that I think is really important to talk about is management of that potential for implications from bone loss. So it's important to monitor bone mineral density prior to the initiation of therapy and then usually yearly afterward. And then again, stress some of that lifestyle management strategies, avoiding smoking to avoid chronic alcohol use, vitamin D and calcium, regular weight-bearing exercises, as well as looking at things such as bisphosphonate therapy or denosumab for prevention of treatment-induced bone loss. Those are some of the strategies I think we can regularly counsel patients about and assure patients are aware of.
Yeah, I think that's so important. And especially when you think about the bone
density and bone health. Those are things that patients necessarily feel until it's too late, until they have a fracture due to bone loss or osteoporosis, osteopenia, those types of things, which, we associate with regular aging. I think it's one of those things that, again, as clinicians, we need to continue to reinforce that as we see patients, every few months, over years of time and years of treatment, that they might not feel that symptom, but it is just as important and significant to monitor and to manage through some of the ways that you've mentioned. So definitely something to keep in mind and keep in the front of our patient's mind as well. So now let's talk a little bit about some of the administration considerations that nurses should keep in mind when we're giving these estrogen targeting therapies.
Because these agents may be obtained through the standard way that patients obtain their oral medications, it's likely that there will be an evaluation of drug-drug interactions. But some of these agents, especially new ones, may need to be obtained through a specialty pharmacy. So I think one of the key things that is important to think about as you're seeing patients is to really do a good med reconciliation. Are there drugs that are new? Should they be checked to make sure there's no drug-drug interaction? Tamoxifen is metabolized to an active agent, and it's metabolized through 2D6. And so drugs that decrease that 2D6, that means you decrease the active tamoxifen agent. So agents such as fluoxetine has been shown to interact with tamoxifen. So agents we may be using to control some of the symptoms of like menopause, such as hot flashes, may interact. So it's really important to make sure patients are aware that they should let you know every time a new drug is started so that you can do a good drug-drug interaction. The other thing that I think has been really shown for years is that adherence is a challenge because these drugs are often used in an adjuvant setting. So patients don't have symptoms of their disease because they're disease-free and you're trying to prevent recurrence. And so sometimes adherence kind of drops off. Sometimes these agents aren't real cheap. So it's really important to reinforce that patients are taking these drugs and taking the drugs as prescribed. And then the other thing I think that's really important is that we evaluate for bone health as patients are on these drugs.
I think those are all great tips. And, it's funny as I think to myself, I don't know if this is right or wrong, but in my mind, for some reason, I partition these hormonal targeted therapies in some sort of different category than all the other sort of targeted anti-cancer therapies that, are obviously very much predominant now with the evolution of genomics and biomarkers and all that. I don't know why I separate them. I think it's just based on my age and years of practice. But to your point, the challenges of adherence and educating and coaching our patients through taking oral therapy at home, it's all the same. It's the same discussion. As you mentioned, kind of when these agents are prescribed for patients in their cancer treatment might be different in terms of primary therapy versus adjuvant. But the notion of adherence and the work that we as nurses, as pharmacists, we need to do to make sure our patients are set up appropriately to not only obtain these drugs in terms of cost, but managing, how they take them at home, keeping themselves on track and on schedule. Most of these drugs, I believe, are just daily dosing. So there's less complexity in terms of the dosing schedule. But again, some of those things still happen in terms of adherence. If they're having uncontrolled side effects, they're not going to want to take it. So all of those things that we maybe focus more so on some of the other targeted kind of anti-cancer therapies, I don't think we, or at least I will speak for myself, maybe I've not always considered those same techniques and applied them to our patients that are taking, bring those techniques and ideas through when we're coaching our patients when they're taking these estrogen targeting therapies.
I agree.
So since we just brought that up, let's talk a little bit about some of those primary patient education points that we need to make sure that we communicate to our patients, their caregivers, and just reinforce on those. Again, we're seeing these patients probably maybe monthly upfront, extending to every 3 months. Actually, maybe we get to every 6-month visits. So what are some of those, key education points that we should make sure that we bring up, ask questions about, and then reinforce when patients are coming to see us in clinic?
I think you did a great job going over them. I think that what you said is exactly right. We need to help individuals on these drugs realize that these side effects that they're having, they don't need to just accept that they can be managed. And if they're not tolerating a drug, there may be a different option, different class that they may be able to tolerate. I think another interesting concept is that coordinating care with their primary care providers to help with some of the management of those menopausal type symptoms that sometimes get kind of rolled up and ignored, such as insomnia. So I think those are some of the really good things to make sure that we do address as we're taking care of patients and with their caregivers. So as you said, adherence, looking at side effects, the cost of care, and also making sure that the side effects are managed appropriately and coordinated with other comorbidities.
Thanks so much for that, Mo. I think we've talked about this and maybe in many of the episodes that we've talked about, but just, reinforcing and then working alongside each other as we are doing right now. Pharmacists and nurses, we know, have a very connected relationship as we care for our patients, especially when they are on these adjuvant treatments that maybe don't feel as intense as those active treatments when they're coming, whether it's for infusion, when they are on these oral therapies and they are coming to see us in clinic. Pharmacy and nurses still have a very close relationship in how we collaborate and we help those patients as they are managing their side effects, their toxicities. So talk to me a little bit about how you see that relationship between pharmacy and nurses as we work together to provide that patient education and serve as that trusted source of information for our patients.
I think one of the best things that we can do is work together with people who this is their specialty. So within my institution, there are individuals that primarily take care of individuals with breast cancer. And I will tell you, they are my resource. They are the people I call to ask questions about things such as, what do you do in this situation? So the recommendation I had about trying to rotate aromatase inhibitors if a patient has arthralgia, it came up because I met a individual in a dance class and she was complaining about side effects. And I went to a resource who worked in the breast cancer clinic and said, what do you do about this? What's your recommendation? So some of this information is not readily available in the literature. And so working with people who see these patients every day can be very helpful. So I have mine identified within my institution. It was one of the first things I did when I came to the University of Cincinnati. And I have her on speed dial to ask, what's your recommendation about this? I think that's one of the best things that you can do for people.
I feel like that extends beyond just this drug class or even just talking about drugs in general, but just acknowledging that we know oncology is so complex. It is nearly impossible for anyone to know everything about everything. And so whether it's in, as you said, whether it's in your own institution, in your health system, maybe it's a different site in your own health system, or maybe it's just another person in your community who works with patients that are dealing with some of the issues that you're encountering, knowing who your resources are and not being afraid to reach out. And I think from the nursing perspective, from oncology, I'm proud to see a lot of those connections taking place on our ONS communities where nurses have questions, have ideas, and they ask their community, they ask their peers on that platform to get that feedback and answer those questions. So I think whether it's a virtual connection point like that, or maybe your local chapter meeting, or just knowing who's in your community, who you can reach out to. I absolutely agree that in this day and age, when there's so much to know and things are changing so quickly, we have to rely on each other to share that information so that we can all provide the best care to our patient possible. So what do you see in the future, Mo? Well, look into your crystal ball. What's the future look like for these agents and their role in the landscape of cancer care?
I think this is one of the most exciting areas of development in cancer. I think the understanding of how estrogen plays a role in breast cancer has led to a number of new strategies that I would never have anticipated. So for instance, it was found that the CDK4/6 inhibitors, think palbociclib, that these drugs work in breast cancer. And it was found that this is because there's a reduction in cellular proliferation of estrogen receptor breast cancer cell lines when you block cells from going from G1 to the S phase in the cell cycle, which is what these agents do. So now you see a combination of CDK4/6 inhibitors with these endocrine therapies for breast cancer. So you can see as we learn more about the biology, there are new strategies. The other thing that I just think this is one of the more wild things that I never thought about. We've learned now that when you deprive over time cells of estrogen, that you will get signaling pathways that emerge and sort of help drive the cancer. So when you have a patient on these estrogen blocking agents for a long time, there are new pathways. And one of the pathways is the PI3 kinase AKT-mTOR survival pathway. So now we have drugs that target mTOR. Everolimus is used. We have drugs that target PI3 kinase, mainly alpha. That's alpelisib. And I'm not even going to say the AKT3 inhibitor that was just this year introduced. So by understanding what we do when we treat, how that affects the biology, there are new strategies that can be developed to treat patients sequentially. And I think that is fabulous. So I think as we're learning more about the biology, we are better utilizing the drugs we have and learning how to sequence them even better.
That's what makes oncology frustrating, but fascinating, and just acknowledging that, as we all know, within healthcare, like, it is not a singular disease, and everyone's individual cancer, morphs in its own unique way. And as you mentioned, like, sometimes we'll have an agent that works, but then it stops working, and there's the resistance that we built up, and tolerance to a certain type of drug. And so understanding those new pathways, other targets that can help, I think it creates sort of this puzzle. It's sort of like a detective work of trying to kind of follow the disease as it changes. Again, frustrating, fascinating, kind of the crux of what we're doing here in oncology care is trying to understand how each patient's individual cancer is unique and what is that best personalized approach to how we treat their disease. Well, Mo, another great episode. Learned a lot, as always. As we reach the end of our discussion today, let's work through our quickfire questions just to help summarize some of the great points we've talked about today. How do you think healthcare professionals can evaluate their hidden or implicit bias about patients who are being treated with estrogen receptor antagonists or other estrogen-targeting therapies?
So I think probably one of the most common biases is to think that all these drugs are the same, and they are so very much not. They have different mechanisms. They have different places in therapy now. They have different roles with other agents, and they definitely have different toxicity profiles. So I think that's the bias. Instead of thinking these are all endocrine therapies for breast cancer, I applaud these podcasts that really delve into the pharmacology, because that impacts patient care.
What are some common misconceptions about these estrogen targeting therapies?
I think there is this concept that hormone receptor positive breast cancer is one disease. And as you just said, it is not. Not only are there disease-specific aspects that we need to look at, there are patient-specific aspects that we need to look at, whether a patient is premenopausal or postmenopausal or male. Those are things that we need to consider. So I think the big misconception that all of these drugs work the same way because all breast cancer is the same, I think that's a big misconception.
What's something about this topic that's not often discussed, but you wish people knew more about?
I have to go back to the whole acquired resistance thing. I think that learning, now that we're seeing individuals on these therapies for a prolonged time and then having recurrence of disease, knowing that there are different strategies, different mutations that may occur, acquired mutations that may be great targets. I think that's the thing that I wish people would pay more attention to and not think a new drug for breast cancer, it fits in this group of drugs and this is how it works. You have to really look at what it's been studied and how it can be used.
Getting more complicated every day, but I think we're learning that this is going to be the heart of oncology moving forward. So great comment there. What additional training or education do oncology nurses need to stay current in this topic?
So this is where I think there are two types of education that are necessary for all of us that work in oncology. There is that foundational information that you get so that you can understand the more complex information that comes out with these new studies. I think people need the foundational information in those diseases that they don't work with every day. So if I'm a person that works in a GU clinic, I still need to know about breast cancer because it's going to impact me in some way at some point. So that's the one foundational. But I think that people need to actually pick up the information about these new drugs to look beyond what they know about them in a class. And luckily, there's lots of information available through meetings, through journal article reviews to help people fine tune in to some of those nuances that will be helpful in practice.
Great. Thank you for that, Mo. And then finally, what are some additional resources for patients or maybe other healthcare providers who want to learn more about these estrogen targeting therapies?
I think the information for patients is plentiful. I think that advocacy in breast cancer has served not only individuals with breast cancer well, but all individuals with cancer well, because there are those resources. So I would say use those patient-developed resources for these agents because it really does do a nice comprehensive review for individuals. And I think providers would benefit by looking at those resources as well, because every time I look at a ONS journal that has something about management of menopausal symptoms, I make a big circle to think about, go back and make sure you read this because it may help a patient.
as always, Mo, it's been a pleasure. I love to always get to talk with you, and I always learn something. So I appreciate you coming again on our podcast, and I look forward to the next time. Do you have any final comments to share with our listeners today?
No, I just really enjoy this opportunity to talk about these drugs in classes because we're so overwhelmed with information anymore. Sometimes we don't go to this foundational knowledge that's so necessary. So appreciate the opportunity.
Thanks so much, Mo.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.